Welcome, everyone. My name is Todd Fetterman. I teach economics here at Montclair State University. Our guest today is Professor Sean Flynn. Professor Flynn teaches economics at Scripps College in Claremont, California. I'm going to share my screen here for a moment. Sean is the author of Economics by McConnell, Brew, and Flynn. He's the current author. He is also the author of Economics for Dummies. And today he'll be talking to us about a book he published in 2019, The Cure That Works. It's an in-depth look at an alternative method of providing healthcare funding, and that it's a system that produces excellent outcomes. Two people I have to thank before we get started. Roger Solomon is the Director of Technology here at the Feliciano School of Business. He was instrumental in putting together all the technology for this meeting. Also on the call today is our moderator, economics professor Orkideh Garagazli. Because of the format, cameras and microphones are muted. During the presentation, when you have a question, please use the chat room box to send your questions to Orkideh, and she will then select questions to ask when Sean's finished. Before I turn it over to Sean, mark your calendars. Let me stop share here. Mark your calendars 2 weeks from today at the same time, 1:30 p.m. I'll be doing a live Zoom presentation. I don't have the link yet. It'll be out soon. It's titled GameStop, Short Selling, and the Extraordinary Popular Delusions and Madness of Crowds. I will be explaining how short selling works. It was an extremely important part of my career. I'll be talking specifically about GameStop. With that, it's my pleasure to turn over our presentation today to our guest, Professor Sean Flynn.
Okay, Todd, thank you very much. And Mr. Solomon and Orkideh for all the help with this presentation. It's an honor to be speaking here at Montclair State. I used to live on the East Coast a while ago, and thank you, Todd, for finding that old picture of me from maybe 15 years ago when I was teaching up in Poughkeepsie, New York at Vassar College. And so I'm a little familiar with your part of the world, and I miss it in many aspects. And so it's indirectly here on Zoom today, a pleasure to be back in that area. So what I want to talk to you about is healthcare reform, and specifically a whole set of alternatives that are by far the best in the world, but no one knows about them. And so I've been given here about 40 minutes to speak and then 20 minutes for questions. So I'm actually going to set myself a timer to keep on schedule here because quite honestly, this is such a rich and fabulous subject that I could talk literally for 2 or 3 hours straight and give you all the details, but I'm going to try and squish everything here into 40 minutes. And so let me begin with US examples. Everything I'm going to describe to you works here in the United States, and everything was invented here in the United States, but hardly anyone even knows that this stuff exists. So for instance, the proper way to use health savings accounts. We invented health savings accounts. Why aren't there price tags in healthcare, right? You go to the doctor and you get a bill 3 months later through your insurance and they tell you something costs. Why can't you get a price tag, a bill in advance? Believe it or not, an American invented the price tag back in the 19th century, John Wanamaker. And high deductible health insurance and how to use it properly to actually protect people and give them financial security while providing them great healthcare. We invented that, but almost nobody is putting the stuff together correctly. There are a few great exceptions here in the United States, like for instance, Whole Foods Markets, the supermarket chain, has done this combination of policies since 2002, and it was approved by both their unions. It's wildly popular with the employees, works great, protects them, provides financial security, safety, and also crucially a reason for them to be consumers and actually shop around for the best deal. Which is something that's lacking in the rest of our healthcare system with traditional insurance. And so all of this, besides Whole Foods, there's a Medicaid expansion program, which I'll touch on later in the state of Indiana. So we know that this program will work for people in the lower income levels in the United States, right? There's a lot of worries about any sort of healthcare reform wouldn't work for the poor. Well, this works wonderfully for the poor, for the working poor, for those unable to work. We have other examples from around the country, but they're here and there. And policymakers generally don't know about this stuff, and neither, unfortunately, do a lot of business owners, CEOs, and management of large companies that could be offering this sort of system, the Whole Food sort of system, to their employees, but they don't even know that it's possible or what the great effects are. So I wanted to start with all these US examples because, and I said hardly anyone's doing it here in the United States, but there is one place in the world where they have been doing all of this stuff for decades, and they're getting just unbelievably tremendous results. And that is the little nation of Singapore in Southeast Asia. And, Singapore is physically, an island nation. It's physically the size of the 5 boroughs of Manhattan. And the population of the New York City and the 5 boroughs is about, I think it's about 9 million. Singapore is at 5 million. So roughly comparable both in size and in population size to the New York area. And so you want to keep that in mind as I make a bunch of comparisons here, right? And, please, before I go any further, it's not because Asian people are healthier. It's not because Asian diets are healthier. It's not because Singapore's small, because if smallness matters, then, or compactness, right? Having a lot of people in a small area, well, then New York should have some of the lowest healthcare costs in the world, and it doesn't. It has some of the highest, right? So don't think that anything I'm about to tell you and these great results in Singapore is due to Singapore being in Asia or having a Confucian culture, anything like that. It's because they adopted our best policies here in the United States with respect to health savings accounts and high deductible insurance and backstopping people, making sure there's price tags on everything. And because of those things that we invented, they're getting both the best healthcare outcomes in the world, as well as by far the lowest costs in the world. As a matter of fact, less than the single payer, so-called single payer countries with national healthcare systems like Canada and England. And so let me just give you the top line spending numbers to put things in comparison and just sort of describe immediately just how much better Singapore is doing on the financial aspects. And then I'll tell you about how much better they're doing on the actual outcomes, right? The quality of care. So we in the United States are spending about 18% of national income, 18% of GDP on healthcare each year, by far the highest in the world, okay? Most of the rest of, developed nations, so we're at 18, England, Canada, France, Japan, you can go on and on. They're at between 10 and 12, right? So if we're at 18 and they're at 10 or 12, this is why people like Senator Bernie Sanders get excited. And they're like, wow, Canada's only spending 10% of GDP each year. We're spending 18. Why don't we adopt the Canadian system, right? And it has other potential benefits like universal coverage, things that you would want, right? A real safety net that would be comprehensive and universal. But, we're at 18, Canada, England, Japan, they're at 10, 11, 12. Germany, you can go on and on, South Korea. Singapore is at 4.2, right? 18, 10, 4.2. So Singapore is spending actually less than half of what Canada and England are spending. And that's wonderful as a counterexample, but it's also a little sad because if you go into a school of public health typically, or a school of government and policy, and you ask someone there about healthcare reform and ask them, hey, if the US system is spending crazy amounts of money here and we've got all these other problems that have to do with coverage and accessibility and prices, and you ask someone at one of those schools, well, what other countries do you look to as a better model than the United States? They will almost invariably talk about only 2 countries. They'll say either Canada or they'll say England, right? Those are the 2 single payer countries they've studied, it's in their mind. And they think that those are the big savings points, but they're not. We're at 18, Canada and England are about 10, Singapore's at 4.2%. Now you might say, okay, they're spending way less, but what are the outcomes like? And how's the universal nature? Like, are they actually covering everyone? And the answer is their outcomes are the best in the world. And they've got the best safety net in the world and everyone's covered and it's completely comprehensive. And so you can't make any good complaints. And so let me give you some of the quality metrics here. So there are 3 big statistics that in healthcare people look to just sort of give a quick summary of how well any country's healthcare system is doing. So one is life expectancy, right? If you're born, how long on average will you live? Another is maternal mortality. And so if a mother gives birth, how likely is she to die in childbirth? And by the way, in traditional societies, pre-industrial societies, there are a few places still in the world that don't have the full benefit of modern technology. Women have about a 1 in 10 chance of dying with each birth. So there are places in mountainous Afghanistan, South Sudan, there's a few places left where mothers don't have the benefit of modern technology. And it's about 1 chance in 10 for each baby, right? Lack of antibiotics and all sorts of other stuff. By contrast, Singapore is usually the lowest in the world or tied for the lowest in the world. And I'll give you the numbers in a second. And then finally, life expectancy, mortality, maternal mortality, which I just talked about, and then infant mortality, which is how many babies die within their first year after being born. And so in terms of life expectancy, Singapore is tied with Japan for the highest life expectancy in the world. It's about 86 years. By comparison, the United States is about 80 years, right? So we're living about 6 years less on average here in the United States, despite spending almost more than 4 times as much as Singapore in healthcare, right? We are living shorter, and not just by 6 months. 6 years is a long time, right? To be dying too soon because your healthcare system is inefficient. With respect to maternal mortality and whether a mother will die in childbirth, the R rate is about 7 times higher. That is, a mother giving birth in the United States compared to a mother in Singapore, about 7 times more likely to die in childbirth, right? These are horrible differences, right? Not 7% more or 70% more, but 7 times higher. And then with respect to infant mortality, our infant mortality rate is about 3 times higher than Singapore's. And so a child born here in the United States is 3 times more likely to die before they hit their first birthday than a child in Singapore. And so Singapore is generally in the top 3 every year in all of those categories, those 3 main categories of healthcare outcomes. By comparison, we're in the 40s and 50s. I think we are currently 40 something in life expectancy. We're about 48th or 49th in maternal mortality. And I think we're around 55th or something in infant mortality, right? So this is really embarrassing, right? We are still the richest, most powerful country in the world. We've got the best hospitals. You know, if a rich Saudi billionaire oil sheik gets some kind of rare cancer, they fly to the United States. They go to places like the Mayo Clinic, right? They go to Sloan Kettering. They go to famous hospitals. You've got several in the New York area to get treated because we have the best cutting edge treatments here. You're also here probably better off getting in a car accident in the United States than anywhere else in the world. We've got more like helicopter medical transport and emergency services, or just, you know, level 4 trauma centers. You can't get that, you know, in other countries to the extent that we have it here in the United States. So there are a lot of great things about our healthcare system, but the overall outcomes, how long people are going to live, do babies die early, do mothers die in childbirth, and a whole bunch of other statistics, we're doing embarrassingly badly, right? You know, when we're behind countries like Guatemala, and I don't mean to say anything disrespectful about Guatemala here. I've got some Guatemalteco friends who are dear to me, but as a country with a healthcare system that's behind the United States, it's embarrassing if they're getting better outcomes than us, or places like Greece, which are substantially poorer. And so what is it that Singapore is doing in Whole Foods markets and the few places here in the United States? Well, it's very, very simple. It's just 2 main things. One is price tags, or what economists like to call price transparency, for reasons I'll explain in a second. And the other is giving people a reason to shop around while also protecting them. And so let me do the price tags first really quickly. You know, healthcare is pretty much the only part of our economy where you can't get price tags in advance, right? Imagine rolling into a car dealership and you're looking at cars, they could be new cars, used cars, and the dealer says, no, we're not going to tell you the prices. Don't worry about the price. We're just we got your credit card on file, and you know, just drive it off the lot today. Here are the keys, and in 3 months we will start billing you something each month. Right? We'll just start charging your credit card every month, right? But we won't tell you now. Or a restaurant. Imagine going into a restaurant and they don't have the prices on the menu, but they're like, yeah, just choose what you want. We'll bill you later. But that's exactly what we do for healthcare. And I know a lot of our audience today is younger and may not have had to yet deal with insurance directly themselves, right? We probably got a lot of students here where their parents handle the health insurance and billing and stuff like that. But the way we do health insurance here in the United States, and by the way, it's unique. No other country does this. We are uniquely stupid in this regard, is that, and for instance, let me use me as an example. I teach economics at a place called Scripps College in California. I have our healthcare, our insurance is through a company called Blue Cross Blue Shield of California. And so what happens is when I go into a doctor, you know, it could be just something minor. I've got like a little case of pink eye or something gross, or, you know, I'm getting old enough. I've got neck pains and stuff like this and back pains. I go in, my doctor, she treats me. What she'll do is she will send the bill to the insurance company, right? And she doesn't know actually what anything costs. There's specialists who work with her in accounting that will bill the insurance company for whatever she did to me. So I'm never told the price at the time the service is being performed. And then that bill goes to the insurance company. They then have a 3-month negotiation, right? It's actually a kind of a debate, right? She submits a bill and then the insurance company denies the claim. And then they negotiate to something in the middle, right? So first base of the insurance company is like, we're going to pay zero. We don't want to pay at all. The doctor's like, I did a service. I need $100 for this to make up for my costs. And then they might negotiate to like $70 or $50. There'll be a negotiation. It takes about 3 months. And then only then after that negotiation is completed, do I get any sort of a bill? And the way the bill looks is they'll say, all right, at the end of negotiation, the doctor got $70 and you are responsible for 10% of that. That's part of your insurance contract. You have to pay 10% of the bill. And so 10% of $70 in this case would be $7. And then there'll be a line at the bottom of this little statement I get in the mail saying, your share is $7. And then I'm supposed to mail them a $7 check or call in and, give them a credit card or something, right? I have to pay $7. But the fact remains that I don't get a bill till 3 months after the service is done. I also don't know even in advance. Like if I ask the doctor, hey, could you call your accountant? I know you're gonna tell me how much you're gonna bill them before the negotiation. And she might call in, the accountant says, we're gonna try and bill them $100. The insurance company, we're sending them $100 invoice here. And then I'd say, okay, well, if it turns out to be $100, then I could do 10% of 100, which is $10. But that's kind of a waste of my time because I don't actually know if after the negotiation, it's going to be settled at $100 or $70 or $45. I just know in some vague sense, I'm going to have to pay 10% of whatever the end of the negotiation is. And so think about how that would work at like a car dealership, right? You don't even know what the price is going to be in 3 months or what percentage of you're going to have to pay. And so we've got this massively opaque healthcare system where anything that's covered by insurance, you can't get the price in advance, which among other things means you can't comparison shop. You can't go from, say you need a knee surgery. You can't like call up 3 doctors and say, well, how much are you charging? And then, decide which doctor to go to based on, who's charging the least money, which you can, like if you're, you want to buy shampoo, you can go to Target, you go to Walmart, you could go to your supermarket and compare the prices and get the cheapest one. But in healthcare, anything that's covered by insurance, you can't get the prices in advance, which means there's no competition. There's none of the benefits that come from capitalism and competition. So anything that's covered by health insurance in this country, which is most of our medical spending, is just completely opaque. There are no price tags. There's no what economists like to call price transparency. You can't see through to what the prices are going to be to make a decision. By comparison, Singapore has price tags on everything, right? If you need a knee surgery or anything else done, just, an annual checkup or, you've got a 12-year-old who needs, a doctor's note saying he's in good health or she's in good health to start, some sports program. Well, you can find out instantly online in Singapore what every doctor charges for an annual checkup or for a knee surgery or for an open heart surgery. And you can comparison shop. And then to make the comparison shopping even easier, the government of Singapore publishes quality data. So you can know whether, the mortality rates, the morbidity rates, the complication rates for all the surgeries at all the different hospitals. And so you could, decide, hey, hospital A over here, it's much cheaper, but 2% of the patients die in this surgery. And hospital B over here, yeah, it's more expensive, but nobody dies. And then you as a consumer can make that decision. And if you're like me, you're probably going to be really cheap about it. And you're going to say, I'll go to the cheaper hospital, even though some people die, I'll take my chances, right? But what this forces in the entire healthcare system is that all the doctors have to compete on both price and quality, right? Because if you're at the hospital as a doctor where, it's cheaper, but 2% of the patients are dying, whoa, you're going to lose a lot of business. So you need to figure out how to keep your costs down while also raising your quality. That'll be your task over there as you're competing for business. Now, the doctors at the hospital where nobody dies, but it's really expensive, they've got a different problem. They're going to be losing some business because it's so expensive. So what they need to do is keep their quality up while forcing the prices down. And so both sets of doctors end up having intense competition. And what you end up with system-wide after a few years of this, and Singapore's been doing this for decades and decades, is you end up with both high quality and low prices, right? The quality goes up with competition, the prices come down, and you end up with the world's greatest healthcare system, where the prices are the lowest and the quality is the highest. And so let me give you an example, just one, right? I went and I researched for price comparison data for surgeries in the United States versus surgeries in Singapore, specific surgeries. And they were on average like 75, 80% less in Singapore, all sorts of surgeries. And let me just give you the number for open heart surgeries, right? My dad needed one of these back in 2004. He was getting quite up in age at that time. He'd been overweight and, hadn't been exercising and all sorts of things. But in the United States here, that would bill out for, $130,000, $140,000 typically. And that's because there's no competition, right? You can't get the prices in advance here. But 3 months later, you'll get a bill, and the bill after the negotiation is like, whoa, $130,000. What the hell is that? In Singapore, the price, because they have competition, is only $18,000. And that's completely unsubsidized by anyone. That's available to anyone. Like if you're a medical tourist, if you want to fly into Singapore for your surgery, you can. $18,000. So they have turned in Singapore what in the United States would be a financial catastrophe for most families, right? Who has $130,000 lying around into something that most families can handle, right? $18,000 is less than half the cost of average new car in America. Last year, the average new car in America sold for about $36,000. And people just put that on payments. They pay it off over 5 years. So here we've got a country where what in the United States would be a catastrophic expense, $130,000. It's only $18,000 there, which means everyone could, if they wanted to, just pay it off in monthly installments, a couple $100 a month, which most people could handle. But they also have the world's greatest insurance system, which means you don't have to pay the full $18,000. Insurance is going to cover most of that. And so let me now explain how that works, because that's the other sort of great thing here. Actually, let me pause 1 second. You also need to know the power of price tags in the United States by looking at the stuff that is not covered by insurance versus the stuff that is covered by insurance, right? So if things are not covered by insurance, they're called elective procedures. Like for instance, I got my glasses here. Almost all health insurance will pay for glasses, right? Because that's a way of correcting nearsightedness and farsightedness and all sorts of other presbyopia and stuff. But they won't pay for LASIK eye surgery, right? LASIK eye surgery, they go in there and they laser scrape your lens in your eye, and they can, get the same effect as high quality glasses. You get 20/20 vision, but that's considered elective, right? Because for a lower price, the insurance company can fix your vision, and they don't want to pay for the higher price of the LASIK eye surgery. Bunch of other stuff is elective, right? Cosmetic surgery, unless you've been in a terrible accident, right, where your face would be otherwise disfigured. Insurance will pay for that. For any type of elective cosmetic surgery, just facelifts, things to make, a rhinoplasty to make your nose a little smaller if you don't like your nose, or they can actually make your nose bigger too. All this stuff, though, that is optional, that's not medically necessary, is called an elective procedure. And insurance won't pay for that. And there's lots of other examples like laser treatments for varicose veins, cosmetic dentistry. There's a bunch of these that are elective, and insurance won't pay for them. And that's interesting because in that part of our healthcare system in the United States, you do have price tags and competition, right? You could, if you want LASIK eye surgery, you could call all the local doctors who do it, and whoever answers the phone there will tell you what the price is. Instantly, the prices in advance, you can comparison shop. And so there's super intense competition because there's price transparency in any part of our healthcare system where there are price tags. But the only places where there are price tags are those that aren't covered by the insurance. Because if anything is covered by the insurance, then the doctor sends the bill to the insurance company. They have a 3-month debate over how much she's going to get paid. And then, you get some bill 3 months later that says you pay this amount, some percentage of the total amount, right? That's really important, because if you look at what's happened to healthcare prices in the United States for what's covered by insurance, they've just gone up 8, 9, 10% a year for the last 50 years. But if you look at things like LASIK eye surgery, they fall every year, right? Over the last 30, 40 years, the cost of LASIK eye surgery has fallen, once you can quality adjust it and adjust for inflation, it's fallen by like 70%, right? Since it was invented around 1990. And so And that's true of cosmetic dentistry, optional plastic surgeries, anything where there is not insurance involved in America, where there are price tags, where there is competition, the prices go down every year, whereas everything that's covered by insurance, the prices go up every year. And so one of the tricks Singapore has done is just to put price tags on everything to bring that intense competition system-wide. And so that is one thing we really need to do in the United States here, is put price tags on everything, so that people can comparison shop and look around for the best deal. And so also that the providers are forced to compete on both quality and price, because right now, they don't have to care that much, because as a matter of fact, you aren't the one paying. You feel like the customer, right? You're in the doctor's office, but the doctor doesn't get paid by you. The doctor gets paid by the insurance company. So all their incentives are to bill the insurance company a lot of money and try and maintain a good relationship with the insurance company, not with you in particular, right? If you are paying your own money, the doctor knows, wow, I better cater to this patient. I want repeat business. I want them to tell all their friends what a great doctor I am. All of that is present here for things like LASIK eye surgery, where they're elective procedures, but none of it's there for your doctor with a stent surgery. And it's not because they're bad people, they're trapped in a bad system. So that's one thing, the price tags. The other thing is, how do you structure a health insurance system so that you both protect everyone and give everyone an incentive to shop around for the best deal, right? Because you want people to have skin in the game. You want them to feel like, yeah, okay, so there's price tags and you want me to, not waste money. How are you going to incentivize me to not waste money? And the answer is, you let them keep 100% of any savings they get. And now the way you do this is you put them on a particular type of health insurance policy. It's called a high deductible health insurance policy. And so let me just throw out the numbers for Whole Foods markets. So at Whole Foods, the workers are required to pay the first $1,875, so $1,875 of their healthcare expenses every year. And then basically everything above that is paid for by the insurance company. I'm simplifying just a little, but this will give you the correct flavor of what's going on in the incentives. So the first $1,875 is on you, the rest is on the insurance company. And what that means is that at least through the first $1,875, you have a really great incentive to shop around for the best deal, right? You're not going to want to pay, $900 for something that you could get for $100. And let me just give an example. You're not going to want to go into an emergency room where everything's really expensive. Your kid's got the sniffles because they're going to bill you $800. You go to the local urgent care center. It could be at, your local CVS. It doesn't matter, but there's a doctor there, and that'll cost $100, right? And so what you want is to give people the incentive so that they will go to the lowest cost provider. And the incentive is, hey, you're saving all that money. It's your money. But how do you give them that incentive, and how do you also protect them? And the answer is, Whole Foods Markets every year gifts each of its full-time employees, right? And that's 30 hours or more working. They gift them the entire amount of that $1,875. And every year that a worker works there, they are gifted that amount. It's called the deductible on their insurance. $1,875 this year, $1,875 next year, $1,875 the year after that. Every single year, the workers are gifted the $1,875 necessary to cover their annual deductible. This then means that they're 100% financially safe, right? They were given the money to cover the annual deductible, and then anything above that is on the insurance company, right? So there's no money this worker is going to have to pay out of pocket, or they're not going to have to sell their car to cover a medical bill or borrow money from their aunt. None of that has to happen because you've actually gifted them the amount of the annual deductible. But you also turn around and tell them, hey, anything you don't spend in a given year out of that $1,875, it's yours. You get to keep it. It rolls over in your health savings account. And, we create special accounts called health savings accounts for this money that can be spent on healthcare. And then every year you get another $1,875. But the deal always is, any money you don't spend, you get to keep. And even after you stop working at Whole Foods Markets, you could take that money with you, right? And so what's amazing is if you look at people's before and after behavior, right? Because Whole Foods didn't always do this. They only started this in 2002. They used to have other more traditional types of health insurance, right? There are things called indemnity insurance. There's PPOs, there's HMOs, there's all these variations in our current system where, there's this crazy billing system where there's the 3-month negotiation. But in all those cases, you could compare the workers as they were before and then after. That is before and after 2002. And what happens is that when workers are given this incentive to save money, right? The incentive is so simple. You're gifted 1875. Anything you don't spend, you get to keep. Such a simple incentive. It turns out that spending instantly falls 35%, right? That is the amount of medical spending the workers are generating every year when they're given this incentive to save money falls 35%. That's such a huge reduction that it more than pays for those gifts of money that each worker gets every year, the 1875. So from the company's perspective, from Whole Foods, there's a 12% net savings, right? Even after the company accounts for the amount of the gifts every year, the medical spending by the workers on the back end falls so precipitously, 35%, that there's a 12% net savings to the company, even after accounting for the annual gifts. Now, why does the medical spending fall 35%? And should we be afraid of that? Well, you shouldn't be afraid of that because the workers are still going in for mammograms just as often. They're going in for annual checkups just as often. They're doing all the preventative medicine stuff at just as high a rate as back when they were on PPOs and HMOs and indemnity insurance. So it's sustainable cost savings. But all of a sudden, when it's their own money and they can save the money for themselves, they get generic drugs instead of brand name drugs. They go to the urgent care instead of the emergency room. They take just very simple steps to avoid wasting any money because they know 100% of any savings belongs to them. So Whole Foods was like a major pioneer among private sector companies and is the most famous example, but there are literally hundreds of companies across the United, well, actually thousands now that are doing this. Big companies, small companies, famous companies. Most of them, of course, are not famous, but the system works and the numbers turn out to be the same again and again. And so let me give you two examples from the state of Indiana. One was started in 2007, and it was for state government employees, right? So if you're a state police officer, right? Or you are a teacher at one of the state universities, or you're, postal worker. Well, no, postal workers are federal, but just any sort of state employee in Indiana, they started offering one of these Whole Foods looking healthcare plans. You call it a Singapore looking healthcare plan because Singapore does a similar thing. And the numbers were a little different. These were family plans. And so the annual deductible was $2,850, so $2,850 a year. But then the state of Indiana came in and said, all right, we are going to gift you. If you choose to be on this type of health insurance, right, this Whole Foods looking thing, this high deductible insurance with the gift, we will give you the amount of the deductible every year, the $2,850. All right. But again, the deal's the same. Any money you don't spend, it's yours to keep. It rolls over in the account. And every year you get another $2,850, another $2,850, another $2,850. And the way they rolled this out in the state of Indiana for these government workers was that the annual benefits fair came around that November, right? If you're in a private sector company or a government company, in November, typically you get to choose your healthcare benefits for the next year if you're working there. And so they kept in Indiana the PPO option, the HMO option, all these traditional insurance options, but they added this Whole Foods looking high deductible thing with the gift. And the first year, 2% of state government employees went into the system. The next year, it jumped up to 70. And then the next year, it was up in the 90s. And it's always been ridiculously high, like up in the 90s ever since, because word of mouth got out. That first year, a few people tried it. They're like, this is great. I'm piling up huge amounts of money in my health savings accounts. This money is mine to keep. Even if I stop working for the state of Indiana, I'll get to take it with me. And so people saw the benefits instantly. And they got and they, meaning in this case, the state of Indiana's government, they followed people, right? They hired a consulting firm to follow people who used to be, for instance, in HMO insurance and then went into this Whole Foods looking thing, or PPO insurance and a Whole Foods looking thing. And what they found was remarkable. Again, a 35% savings. People suddenly were using generics instead of brand name drugs, like before on the other traditional types of insurance where almost all the bill gets paid by the insurance company for your drugs. 93% of the time, people were choosing a brand name drug when a generic was available, right? They're chemically identical. They do the exact same thing, but one of them will have a familiar name like Tylenol, right? Which gets advertised like crazy rather than ibuprofen or Motrin versus acetaminophen, right? They're generics that are identical and do exactly the same thing in your body, but people, have seen the advertising and they'll naturally gravitate towards that unless it's their money on the line. And so the rate at which people went for the brand name instead of the generic went from 93% down to 13%, right? Only, and there was no education involved. You didn't tell people, oh, these are chemically equivalent. Just give people the incentive that says, look, these two things are equivalent. Any money you save is 100% yours to keep. And then suddenly people are making decisions like that, and they're going to the urgent care center and this and that. But it's still the case with these government workers in the state of Indiana. They're still going in for mammograms just as often. They're still going in for annual checkups just as often. They're doing all the preventative maintenance. They're just not wasting money. And so that's great. That's amazing. And then in 2011, the same state of Indiana, they've been very innovative. So in addition to the government workers, they decided to say, hey, it's going to look like, because the Affordable Care Act, what we typically call Obamacare, had been passed the previous year in 2010. So it's now 2011, and Obamacare is being rolled out slowly. It wasn't fully implemented until 2014. And so people could look ahead. They said, this thing's going to be passed. It's going to be implemented in stages. Are there any holes in the system? And it was noticed in Indiana that there'd be a lot of working poor people at minimum wage who were working at companies that were too small to provide health insurance to their employees. But these people, because they're at minimum wage, wouldn't otherwise probably be able to afford any form of health insurance under the new system, even with the various subsidies that are present in the Obamacare and the Affordable Care Act. And so the state of Indiana tried to get ahead of this, and they did. And they said, all right, let's see if we can insure these people. And what they did was they created a system. It looks like Whole Foods, nearly the same, except the numbers are a little different. And so they said regular Medicaid, which is what the only thing these people have been qualifying for so far, it's first dollar coverage, meaning everything is paid for by the government, the first dollar, the second dollar, the third dollar, and so on. But in a system like that, people don't have a strong incentive to not waste money. So if you've got a kid with sniffles and you know that the government's going to pay 100% of the cost if you go in to have the kid looked at, and the emergency room is right next door, but the urgent care is 3 blocks away, well, you'll just go to the emergency room because 100% of the cost will be on the government. But the emergency room might charge $800 for that visit, whereas the urgent care, 3 blocks away, would charge only $100. And so under traditional Medicaid, you've given people a lot of perverse incentives, right? Same thing with the brand name versus the generic. The brand name might be 3 times as expensive, but if the government's picking up 100% of the cost, what do I care, right? So you want to give people incentive to save money, right? Both for themselves and for the government. And so in the state of Indiana, they created a version of Medicaid. It's called the Healthy Indiana Program. You can look it up, HIP, Healthy Indiana Program. And there's an $1,100 annual deductible. And everything above that's on the government, like regular Medicaid. But for that first $1,100, people are supposed to pay for it themselves. But these are working poor, they're at minimum wage, they probably don't have $1,100 in any given year to spend on healthcare. So you gift them the $1,100. You gift them the $1,100, and that turns out to be enough to not only make them 100% financially safe, right? Because they were gifted the $1,100, and then anything above that is on the government. So these people don't have to spend any money out of pocket. But you make them the same deal. You say, hey, any money you don't any money you don't spend, you get to keep, right? So if you go to the urgent care instead of the emergency room, all that savings belongs to you, right? And so you suddenly give people a very different mental world in which they're operating, a different set of incentives, right? So we don't want to talk about good people or bad people or wasteful people. No. A lot of human behavior, both good and bad, is simply the environment you're placed in and the incentives you're given. And so state of Indiana created these much better incentives, and they told people you're going to get $1,100 every year to cover that annual deductible as long as you're in the system. And any money you don't spend is yours to keep. And so they found the same sort of things. Healthcare spending fell by about 35%. And even after accounting for the annual gifts of $1,100, there was like a 12% net savings. So this thing is massively powerful in terms of incentives. But you might be asking now, wow, okay, you started off this lecture, Professor Flynn, by pointing out that Singapore is spending about 75% less than the United States, right? We're spending about 18% of national income. They're spending about 4.2. That's about 75% less. But so far, Professor Flynn, you've only told us about this insurance system, the high deductible insurance with the gifts that causes healthcare spending to fall 35%. So why is it that those things only get 35% savings, but Singapore has 75%? Where's the rest of that savings? And the answer is it's in the price tags. in Singapore, people not only have the incentive to go out and shop around because they're given, and Singapore does the same thing. There's money in people's health savings accounts to cover their annual deductibles. But when they go out, there's price tags on everything in Singapore. Here, these people on the Whole Foods plans, or the workers in the state government employees in Indiana, or the Medicaid expansion program, the Healthy Indiana program, they are, not faced with price tags in most cases. If it's an open heart surgery or something bigger, or, something more catastrophic, there's no price tags. And so they can't comparison shop. So the difference is, here we can give people the incentive, right, by putting on these plans like Whole Foods, but they don't have the benefit of actually seeing price tags everywhere and getting the benefits of competition. And so a way to look at this is to say, all right, state of Indiana government employees are 1% of the workers in Indiana. I looked it up. So if 1% of the workers in Indiana go on these healthcare plans and they spend 35% less, would anyone even notice? Like, if you're running a hospital and 1% of your customers spent 35% less, it would be a blip, right? Same thing with, say, a Walmart, right? If 1% of the customers at Walmart spent 35% less, they would barely notice it, because that'd be 1/3 of 1%, basically. It'd be barely noticeable. But now imagine if you put every worker in the state of Indiana on one of these plans, and every worker cut back 35%. Well, then if you're running a hospital and every single person coming in cuts back 35% on their spending, you would be forced to notice. In the same way that if Walmart had 100% of its customers, oh, there goes the alarm for time. If Walmart had 100% of its customers cutting back 35%, they would know, oh my goodness, we need to do something. And what they would do is they'd figure out ways to cut prices and deliver better quality care. None of that is present in our current system, and also there's no price tags on most of it. So if you do the price tags, along with putting everyone in a system on one of these Whole Foods looking plans, that's how you get to the Singapore level of savings, right? We could go to single payer, right? We could go full Canada, right? That would take us from 18% of national income down to 10. But what we should do is all this stuff that Singapore borrowed from us and go down to 4.2%. And let me just finish here. I see Professor Gargosli has questions, but let me just finish one more minute by pointing out just how much money that savings is, right? So we're at about 18. We should be down at around, call it 5%. Singapore's at 4.2, but let's be conservative and say 5%. That's 13% of GDP we should be saving, right? 18% minus 5% is 13%. How much money is that, right? Well, one way to answer it is it's about $2.6 trillion a year. But what does 2.6 trillion mean, right? So let me give you some comparison figures. How big is 13% of GDP? Well, last year, the entire defense budget of the United States was only about 4% of GDP, right? Last year, every Social Security check that went out to seniors and every SSDI disability check that was sent out by the Social Security Administration, only about 5% of GDP, right? We've been running, because of this crisis the last year, we've been running some massive budget deficits, but in a normal year, a budget deficit's maybe 2, 3, 4 billion, right? There is so much money here. This 13% of GDP is epic. You could balance the federal budget. You could balance our Social Security system, which is about to go bankrupt in the next few years. The Medicaid system has a $29 trillion hole in it. You could balance all these things. You could fix every underfunded pension plan in the country and still have like $1 trillion a year to spend forever on roads, bridges, education, free student loans, anything you could imagine, no matter what your political preferences are, that we need to spend more money on in the United States. It's there in our healthcare system. We should not be spending 18% of GDP or even 10. We should be spending something more like 4 or 5. And that would free up massive resources for any sort of other spending program you want. So to me, this is the easiest public policy problem in the United States that we already know how to solve. And so let me stop there, and I'm sure there are lots of questions I'd be happy to answer.
Yes, thank you so much, Sean, for this interesting, presentation. I mean, you had been working on this topic even before the pandemic, and these days after the pandemic, after the recent, presidential election conversations, which the healthcare system was one of the points of the conversation, this topic has been even further noticed and highlighted. So thank you again for your presentation. presentation. So we have so many questions. I'm going to start, going through them. Hopefully we get to answer a few of them. So you explained very well what the issue is, and you explained really well, a possible solution, that can fix the problem. But I was wondering if you can explain to us why there is no price tag in the United States. Who's benefiting from that? Is it, the big pharma? Is it the insurance companies? Is it the doctors? Again, you explain what the issue is, but I was wondering why that exists here in the United States.
So as a purely technical thing, the way it's been explained to me is that when Medicare and Medicaid got rolled out in 1965 as part of President Johnson's Great Society programs, they went to this medical billing system that had a bunch of basically codes, billing codes, right? So there's a different billing code if you get your finger cut here and need stitches versus you get this finger cut, right? There's now 64,000 billing codes. And so the system just evolved on billing codes. It was the simplest way at the time for the government to do things. And so, but that meant how much is the government paying for each billing code? So there's actually a committee at Medicare and Medicaid Services each year that actually sets the government's reimbursement rates for each billing code. And so my mother, for instance, she was an eye surgeon. There was a billing code for cataract surgeries, which are very common in older people. And each year the government would just lower the reimbursement rate, right? To try and keep costs down. Now, unfortunately, that doesn't work to keep costs down because then doctors just figure out something else to bill for, right? If they can't bill the government, or if the billing code for the cataract surgery doesn't get you as much money, then you figure out 5 or 6 other things you could bill the patient for and send the bill to the government. And so the system, because of that, it's just a technical thing. Like, how do you run a giant bureaucracy in a way that reduces fraud and stuff? There are certain benefits to having the billing codes, right? But even with the fraud, it's estimated by Medicare itself that maybe 10% of all the billing is fraudulent. Like, someone is billing the government for procedures that were never performed. And so there are a lot of problems here that are solved when it's an individual walking into the doctor's office, because that doctor can't commit fraud as easily, right? He can't get the patient's money unless he actually does something. The patient won't actually hand over the cash, right? And so this is another benefit for, doing it sort of the more cash and carry direct payment way rather than the billing codes. But my understanding, the best answer to the question you just asked is we decided arbitrarily on billing codes in 1965.
So do you expect any resistance against, having price tags from insurance companies or from big pharma?
Yes. So starting with the Obama administration, there were little steps taken, and then the Trump administration continued them to do more and more price transparency. So the last year, the Obama administration, they started making every hospital in America post what are called the charge master prices and print them out, and they have to be kept in the facility. But the problem with these charge master prices, they're not the real prices. They're the ones that the hospital sends to the insurance company at the beginning of the negotiation. They're not the ones after the negotiation is completed. So they're kind of nonsense prices, right? Because of course the hospital is going to ask for something insane and hope to negotiate someplace in the middle. The Trump administration in increments, we now next year, I think, are going to, or maybe it's this year, require the hospitals to post those charge master prices online, right? But the Trump administration got shot down with other efforts, right? They wanted the real negotiated prices, right? And you asked about special interest and things like that. As soon as the Trump administration announced, I think 2 Novembers ago, that they were going to do that, within 3 hours, the American Hospital Association sued, claiming that if they were forced to reveal the actual prices they paid or the money they're paid by the insurance companies, it would lead to price collusion. That is, wow, we're all actually going to be tempted to lie and cheat, basically, if people know how much we're getting paid, right? But you don't say that at McDonald's, right? They can't tell you their prices, because if they, showed you the prices on the menu, they might have the same prices as Burger King, right? They might all collude on the same prices, but that was their argument, and that's still in court. And then the Trump administration also tried to have every TV commercial for a pharmaceutical, for a drug, right? Levitra or whatever, all those Lipitors and stuff for heart stuff. There's a lot of them advertised. Every TV commercial was going to start having to have the price of the drug at the end of the commercial, right? So people could start getting a sense of the prices and price comparison shop. That unfortunately was shot down by a federal judge who actually apologized in his ruling. He said, this is a great idea. Unfortunately, the way the laws were written, the Trump administration, no administration has the authority to just order this. And so there have been several attempts over the last 4 or 5 years to introduce more and more price tags and price transparency, but they basically got nowhere. And part of it is the special interests immediately suing to try and prevent it, which of course, to my mind means, well, obviously that means they think that not showing you the price tags increases their profits, right? If they don't want you to see the price tags, clearly they must be benefiting in some massive, awful, fraudulent way.
Exactly. Okay, thank you so much. So we have so many questions about the comparison between United States and Singapore. For example, some of like I know you explained initially that in terms of health we can compare logically the individuals in these two countries, but still we have many questions about whether the behavior, non-health related behavior of individuals in the United States is different, and also on the other side, like what is in terms of the service, the quality of the service that people receive in Singapore, is it lower than the United States, and how do you compare these two countries?
Okay, so let me start with the quality. So most of the physicians, actually, with the exception of, there's now a medical school in Singapore, sorry, the last 10 years. But before then, all the physicians were trained abroad, the vast majority of them in the United States, right? And they're at top institutions. They went to Stanford for med school or Johns Hopkins, right? They're virtually all board certified in the United States, so they're licensed to practice here. If you go to a hospital in Singapore, they're completely modern. I made sure to even visit public health clinics run by the government in the worst neighborhoods in Singapore, which, by the way, aren't that bad. Singapore is a very prosperous place. But in 1965, at independence, Singapore was 80% poorer than the United States. GDP per person was 80% lower. It's now 20% higher. And so they built this amazing system with this universal safety net when they were very poor, actually, which makes it more embarrassing for us that, we aren't getting this level of quality and service. But if you go to one of their hospitals, it's world-class. And I've even had like hospital administrators, like this one guy who used to run hospitals in Denver, tell me they would fly certain patients. It depended on their insurance situation in the United States. They would fly them to Singapore or Thailand for open heart surgery, first class, fly them back first class, put them in a 5-star hotel for 2 weeks to, visit their doctors after the surgery. And it was cheaper than doing the surgery in Denver. Right? That's the crazy system. And of course, they wouldn't have sent them overseas. Our system here, if they thought the patients were going to die because the hospital would get sued, right? So clearly, even the insider professionals here in the United States recognize that the quality in the United States, in Singapore is at least as good as ours. And the exception though is super high-tech, cutting-edge stuff. We still have the edge on everyone in the world on medical research, right? So for cutting-edge procedures, yes, it's still better here, but for something like an open heart surgery, right? This is 60-year-old surgical technique now, completely standard worldwide. Yes, go to Singapore, get it done for cheap. Knee surgeries, hip surgeries, stents, heart valves, many kinds of brain surgeries, right? Just as good.
Yeah. Thank you so much. I'm not sure if this would be an appropriate question, but can you clarify a little more about the tax on the healthcare system, maybe in the US versus the Singapore? Is that included in your research? Who's being taxed, and what is the difference between the two countries, maybe?
Well, so here in the United States, we have payroll taxes, right?
Mm-hmm.
So, there's if you look on your bill, you have to make contributions into Medicaid and Medicare, as well as Social Security. And there's various other taxes. So I guess one way to say it is, yes, the United States, we tax, but we don't tax enough. That's why there's if you look over a 75-year planning horizon, there's currently, I think, a $39 trillion hole in the Medicaid budget, or Medicare budget, and like another 30 trillion in the Medicaid, which is one of the problems in our system. We don't realize how expensive it is yet, even though 18% of GDP is really high. That should actually be higher. If we were actually collecting enough in taxes to pay for stuff, it would have to be higher. And so someday in the future, we're going to have to raise the taxes. Singapore does not have any direct taxes for the healthcare because they handle the funding differently. So, and they do something that I don't think we could do politically here. So in the United States, I think we need to rely on gifts from the company like Whole Foods, or gifts from the government, from the state of Indiana to its government employees to fill up those health savings accounts to cover the annual deductibles. But in Singapore, the way they handle it is just healthcare saving accounts are mandatory. When you're born, one is created for you. The government gifts $3,000 in. But by the time you're an adult and working, you have to pay 7% of your gross income into your health savings account. That's how they fill them up there. And then that money is used also to pay for annual insurance premiums, as well as deductibles and copays and these other things I didn't, define in this talk that maybe some of the students aren't familiar with, but that's the funding system. Now, you could call that a tax, right? But that actually is people's personal property. If they die early for any reason, they can leave it to their heirs and assigns. They can leave it to charity. If they get to retirement age, they get to start pulling that money out of the health savings account a little bit at a time every year and putting in their retirement savings account, which allows them to spend it, right? So is it a tax? No, it's more like a system of compulsory savings. And as a behavioral economist, one of the things we study is that people are naturally short-sighted. Our ancestors didn't live that long. It's hard to convince modern people to plan for long-term in the future. And so actually getting everyone to save more is really important. That's why, for instance, we have a Social Security system. But in addition to Social Security in Singapore, they have required mandatory health savings, and that's how they fill it up. So you could call that a tax. But in some sense, I think it's just getting people to do what's actually sensibly in their better interest. We can have a philosophical discussion on whether that's appropriate or morally and ethically, but as a practical matter, it works really, really well. People get to be living in the country with the healthiest population in the world and the lowest healthcare costs, which means that these people get to spend a lot of money on stuff like better houses, cars, more education for the kids, that here they'd have to be spending on our outrageously expensive healthcare system, right? So overall, the quality of life is much improved, oddly enough, by requiring people to save 7% of their income into these health savings accounts.
Thank you so much. I totally agree with you. Maybe as the last question, because we are reaching 2:30, I found this question interesting. Have you spoken to elected officials in Washington? How do we get success?
So I have. I actually got so pissed off at this. There's still traces of this on the internet, that I was a congressional candidate in 2016 and 2018. And in 18, I was on the November ballot, California's 31st congressional district. The reason I ran was I was not getting any traction with elected officials, right? An early copy of the book that got published in 19 was actually finished in 2015. And, I printed out some copies and spiral bound them. And I physically myself handed copies to Senator Dianne Feinstein of California, Senator Rand Paul of Kentucky got one, Marco Rubio got one. I mean, so both Democrats, Republicans, some Congress people, but the politicians are so busy trying to get reelected and fundraise that they will just say thank you. And they're very sincere. And, Rand Paul's actually a medical doctor, right? He has the expertise to digest this stuff, but then they just hand the book to the 22-year-old aide that's standing next to them. And 2 weeks later, you get a thank you card, a generic thank you card. And so I actually ran for Congress because I wanted to be on the subcommittee that actually writes the reform legislation, right? There's 2 committees in the House of Representatives that do this. One part of appropriations, the other part of healthcare. But I did that because from what I've seen, it's almost impossible to change anything. And part of it is just ignorance, right? People, when they find out this is possible, say, why the hell aren't our politicians doing it? Well, for one thing, the politicians don't even know. And then let me just end with this because it's really depressing and it's in the last chapter of my book here. The amount of lobbying money by the special interests is just epic, right? If you look at the top 20 industries that, spend money lobbying Washington, D.C., 5 of the top 20 are healthcare related, including the top 2, which is insurance and pharmaceuticals, right? The insurance, those guys spend 5 times more than defense companies lobbying the federal government, right? If you think of, these major defense companies as having a reason to lobby, these people are making out like bandits, right? We are getting mediocre healthcare at 18% of GDP when we should be getting great healthcare at 5%. Where's that 13% going? Well, it's coming out of my pocket and it's going into some insurance company or something like that. So yes, the chances of good reform here between the ignorance thing and the lobbying are small. So even though I prefer this sort of system that Whole Foods uses, probably the most likely political outcome in the next 10 or 20 years is that we get something that looks like Canada or England. It's just easier to explain to the politicians. It's easier to explain to the public. There's already a lot of momentum. That was, Senator Sanders' major talking point for 2 presidential cycles. And so, unfortunately, though, I don't think we get from 18% down to 10% like Canada and England, because so much has already been baked in to the current system. And once the lobbyists get through with it, we will have expensive government-funded healthcare. It will still probably be at 18% of GDP. It's just everything will run through the government rather than anything in the private sector, which is unfortunate, because we should be doing what Singapore did, which was take all our best ideas and spend only 4.2% on healthcare.
Okay, thank you so much. I just want to thank you for one more time for this amazing conversation. I apologize to everybody who had questions. Unfortunately, we ran out of time, and I leave it to Todd. Thank you.
All righty, Sean, I just want to say thank you again for doing this. We've had this weird year in pandemic, but let's lean into the things that are good. We can have a guest speaker come to us from California or wherever you are right now. Come to us from California. And that's something that we really can appreciate and take advantage of. So again, thank you very much for doing this.
Okay, my pleasure. Thank you. And thank you everyone who joined us today. I hope it was useful.
All right, take care.
Okay, bye-bye, Todd. Bye-bye, Orkidea. Thank you, Professor Zaman. Bye-bye. And
Bye.
Roger.
Thank you.
Thank you very much.
Okay,
Thank
bye-bye.
you. It was wonderful.
All righty.